تامر خلف will talk about this subject.
سؤال بالنسبه للدكتوره سوزان، موضوع البيت سي تي في اللنج كانسر، بتتصرفي ازاي في الفولس بوزيتيف كيسز في الانفلاميشن او الفايبروزس، وازاي تفرقيها باللوكال ريكارنس؟ بتتصرفي ازاي؟
ما هو احنا طبعا لو لقينا حاجه بنكورليت البيت فايندينج مع السي تي فايندينج، مش بس بنقول انها دي اكتف يبقى دي مالجنسي، حسب السي تي فايندينجز، وفي الاخر برضو البايوبسي في الاخر بنقول للعيان فور هيستوباثولوجي كورليشن.
طبعا عندنا اكسبيرينس كويسه الحمد لله في البيت سي تي في اسكندريه، كنا بنطبق الديليد فيز. الديليد فيز بنعمل ديليد فيز، الانفلاماتوري الابتيك هيقل انما التيومر هيزيد، فاحنا بنستخدم الديليد فيز في البيت سي تي. بعد نص ساعه بندخل عين تاني بنعمل له ديليد فيز، بنلاقي الابتيك بيزيد.
يا سوزان حاجه كمان سوزان قالت برضه حاجه ثانيه، قالت انسيدنتال فايندينج. ما هو العيان اوريدي عنده شيست مات، فازاي انسيدنتال فايندينج؟
في بيرسنت من العيانين بيبقى عندهم دبل برايمري.
لا بس انا قلت انسيدنتال فايندينج لما تكون اوريدي العيان ده، انا اول حاجه اشوفها كده يعني، حتى عندنا في تقابيل التروما سواء في الثيرويد سواء في الليج سواء في الشيست يمكن كمان فانا ما قلتش انسيدنتال فايندينج، قال لك بتكلم عن اوريدي انا ما عرفتش حاجه ثانيه خالص، حاجه ثانيه.
ما هو جاي يعمل بيت سي تي مش عارف، هو عمل سي تي تشيست، هو عمل سي تي تشيست ولقى عنده لونج باك، فجاي يعمل بيت سي تي فلقينا other lesion which is active.
معلش بعد اذنك طالما اوريدي هو جاي يعمل معلش لكن انا اوريدي العيان ده جاي يعمل بيت سي تي، عمر ما هيجي عيان بروستات يعمل بيت سي تي، صح؟
ما هو الليجن الثاني هو اللي incidentally found.
مش انسيدنتال، طالما اوريدي عيان جاي يعمل بيت سي تي وهو نون كيس اوف مالجنسي يبقى ازاي انسيدنتال؟ انا اعترض على الكلمه دي.
انا قصدي على الليجن الثاني هو اللي incidentally found.
يعني حتى في شركه الدبلومه الاول يعني انسيدنتال ازاي؟ الدبلومه انا مثلا عيان عنده ثيرويد ومفيش حاجه خالص، انا شفت لك اول مره شفت لك الكمبيوتر بس انا والكل في الدبلومه ساعات حتى في الفيزياء في البتاع برضه كده في الشيست لكن عيان اوريدي جاي يعمل بيت وعمر العيان هيبدا بالبيت دي اللي كانت اوريدي عندي فبالتالي انا بعترض
الابتيك في المالجنسي هيقل مش.
دكتور احمد، لو بنعمل ام ار ديفيوجن على بالمونري مديول، هل في كات اوف فاليو في الاي دي سي اقدر اقول دي بناين ولا مالجنت؟ مفيش كات اوف فاليو،
مفيش ديفينيت، لا مفيش ديفينيت.
الرول اوف ايمجنج فيزيشن في البالمونري امبوليزم بقى عظيم جدا، مش انه كان بيودي العيان للتراب زي الاول، لا ده هو بيكتشف، حتى بيكتشف الحاجه الصغيره ويفولو اب التريتمنت، وبعدين ممكن جدا العيان يبقى هم مش يعني خلاص شايفين الصور مفيش حاجه، لكن لا ده بالبرفيوجن والحاجات احنا بنقدر نقول كذا، وفي نفس الوقت وبعدين في نفس الوقت بنقول له حتى كمان it is not functionally significant، يعني انت صح شايف بالون بس الايه البرفيوجن كويس بتاعه، لا استنى ما تعملش حاجه، بس بنمشيه، احنا اللي بنمشيهم احنا اللي بنمشيهم الوقت، ودي دي حاجه جميله قوي، المفروض يعني الاجيال الجديده يعني بتوع الايمجنج فيزيشن ياخدوا بالهم منه كويس قوي، ان احنا بقينا احنا اللي بنمشي، احنا وي ار ليدرز في الحته دي يعني، ودي حاجه عظيمه. كنا الاول مصوراتيه بس زمان ايام يعني فده احنا بقينا زي الرساله، انا دايما كنت اشرح اقول لتلامذتي زمان قوي ان ان الاشعه دي ترانسليشن اوف ذا باثولوجي انتو ايمجز، فبتاع الاشعه كويس عشان يبقى بتاع اشعه كويس لازم يعرف باثولوجي، ولازم يعرف حتى ايفن يعني اللي بيشتغل بالمونري لازم يبقى مستواه في الشيست زي بتوع الشيست بالظبط، بجانب ان هو بتاع اشعه، فيعني بجانب ان هو بيشوف الصور. فده شيء جميل جدا ان انت دلوقتي انت راكب البرانشات كلها، وده شيء يعني ارجو انكم تحرصوا عليه. يعني ارجو ان الشباب الجديد كله يحرص عليه، انه يبقى مش مجرد انه يبص في الصوره بقى، لا يقرا باثولوجي ويعرف ويتابع العيان مع الفيزيشن، علشان زي ما قلت لكم ان imaging is translation of the pathology into imaging. زي الواحد اللي بيترجم من فرنساوي لعربي، ممكن يمسك قاموس ويترجم كده، لكن لا، لو هو اتعلم العربي كويس وتعلم الفرنساوي كويس هيترجم الروايه دي بنفس روحها، ودي فرق. انت ممكن تمسك قاموس وتترجم اي روايه في الدنيا وهتقول حرافيش المحرفشه بتاع حاجات من دي، لا، انت لما بتعرف، يعني انت مثلا كبلمونري ايمجنج فيزيشن، انت بتعرف شيست كويس وبتتابع العيان كويس، هتلاقيك مستواك حتى، وبرضه بالنسبه للماسكول سكليتال وهكذا بالنسبه للنيورو، هتحس انك انت فعلا انت اللي راكب، ويعني ربنا يوفق.
ليه؟ هل احنا ممكن نعمل روتين للبلمونري انجو باللو دوز ومينيمال كونتراست؟ وده لو احنا عملناها هتبقى جميله جدا.
باعتبار ان احنا معظم الحالات دلوقتي بتاعت السي تي شيست بتجينا نون كونتراست بسبب سوء فهم موضوع الهاي ريزوليوشن والكلام ده. فهو من ضمن الحاجات اللي بنعملها دلوقتي ان احنا بنبتدي بنقلل الدوز بتاعت السي، لا بقلل الكيلو فولت. لا، ما هو الفحص اصلا نون كونتراست. لا، ما هو الحقيقه موضوع البلمونري يعني ده المفروض ان ده ثيوريتيكال، المفروض الحقيقه يتجرب. هل انا اقدر اعمل بلو دوز كونتراست، اقدر اعمل بالمونري انجيو يعني ريلايبل ودايجنوستيك ولا لا؟ بس مبدئيا دلوقتي اللي ممكن كلنا نقدر نعملها ان احنا نقلل الدوز بتاعت السي تي لو هيتعمل لون كونتراست، لان نفس البيهيفير ده بيحصل مع الايرون اللي في البلد. فبتلاقي الكاردياك تشامبرز لو عملت السي تي لو دوز اللي هو اصلا لو كونتراست وكمان لو دوز، هتلاقي ان الكاردياك تشامبرز منوره شويه كده، يعني شويه انهانسد، بتديك امبريشن كده كانه هو محقون، كانه يعني برضه يعني حقنه خفيفه كده. فدي اكيد بنعملها دلوقتي، يعني دي بتكمبنسيت شويه بالظبط كده.
ثانية واحدة. يعني يعني كان نفس السؤال. لا، ما انا قصدي كده يعني زي تيوم الحقيقة، وكل ما يزيد كل ما يزيد كل ما الباكينج بتاع السيلز يبقى اعلى، بالتالي المالجنسي مور فيريولنت. حتى بالنسبه لي انا لما بعمل بايوبسيز، لو عيان عامل MRI وعامل بشوف الهايس. انا شفت المحاضره بتاعتي، انت عملت وريت واحده فعلا كده، يعني it is comparable to the PET. it's comparable with the PET يعني without injection of ionizing material. يعني it's value الحقيقه كويسه جدا.
مساء الخير. مساء الخير. My name is Tamer Khalaf. I'm the general manager for MR business in GE in the region. I was hearing the discussion and the debate about the best modality for imaging. I think it's safe to assume where I stand, given my role. I'm not from a medical background, I'm from a technical background. I'm here today to discuss some of the latest innovation in MR, mainly deep learning reconstruction, which is a type of artificial intelligence, and how we implement this in MR imaging and MR reconstruction and the impact on daily clinical practice. So I'm going to show some examples from sites in our region. I'll show some clinical examples as well as some quantitative analysis of the impact it did in our sites. So to start with, I'm going to show two images, and if I can get your help, please, and indication of which one do you think is the better image. You can yell it out if you want. Which one? The one on your right, correct. It's Tamam, thank you for this. So the comment was, the one on your right is a filtered image. Great point, we're gonna get to this in 1 minute. But we all agree that the image on the right has more resolution, we're able to see more details. What about this one? Which one do you think? Doctor, if I can get your comment again, which one do you think is better? Again, the one on your right, is that the... It has maybe less noise, more resolution? Yeah. So this is great conversation because I think this leads to the next discussion. Typically, when we're trying to get more resolution, more signal to noise ratio in our images, we know that we have to compromise on time. Typically, it's going to take us longer in the conventional way of imaging to get a higher resolution, a higher SNR image. This is just typical in MR. So we're always fighting between image resolution, spatial resolution, signal to noise ratio, and time in the conventional way. So what we've done in GEMR lately is we've introduced an aspect of artificial intelligence, mainly what we call deep learning. It's a network, a smart network, that is able to work on raw data, case space of MR, to identify the noise in the case space, in the raw data, and remove the noise, as well as some other artifacts that are inherent in MR reconstruction, for example, Gibbs ringing. So what we're able to do is remove this noise. And if we go back to the images that we discussed, the image on your left is case space done in a conventional way of reconstruction. So you get the image that you're probably more used to in MR. We use the same raw data, and instead of doing a conventional way of reconstruction, we use the deep learning network and actually remove the noise from the image, and you get the image on the right. It's the same raw data, same case space. We applied no conventional filters. We simply used a deep learning network to actually remove the noise from the raw data before we turn it to the image space. The image in the middle is actually the noise that was removed. So it's just a simple subtraction to show the noise that we actually removed from the image, as well as Gibbs ringing, not just the random noise. So if we go back to the original images that I showed in the beginning, what we were able to do is take improved spatial resolution. The image on the right has a better spatial resolution. We're using smaller pixels, and it was actually done in less time. And if I zoom in, I'm sure all of you can appreciate the details we're able to see, especially around the cartilage. This is what additional resolution, smaller pixel size is able to give us when we're looking at the images. And then if we visit the other image again, we're able to see that, yes, our pixel size is smaller, we have better spatial resolution. The difference between the two images is not a conventional filter. We're actually acquiring a different image with higher spatial resolution without having to compromise on the time. So our time is actually less, and of course, this is what allows us to see more details in the anatomy that we couldn't see before. So we're no longer doing this trade-off between spatial resolution, SNR, and time. So you say, how can this benefit us in our daily clinical practice? There's a few instances where you need this higher spatial resolution. You're bound by time, and I'm going to show you some examples of these exams. The first one is diffusion. This is an example from one of the first sites in our region to implement this in Saudi Arabia, King Fahd Medical City. They have a 1.5T from GE. This was a follow-up patient. The image of the diffusion you see is on the bottom. And then they came in 2021 after the upgrade was done. And I hope you can appreciate on the image the adrenal glands that are zoomed in on the image and the details you're able to see with the diffusion that maybe you could not see before. While at the same time, simultaneously, we're reducing the scan time of these images. So this is one example of how we can improve the resolution in diffusion imaging as well. Because this is a deep learning network, we're not bound by anatomy, we're not bound by sequences, we're able to apply it on on the majority of the sequences, and we're not bound by anatomy. Another example of sequences where we are bound by time, we have to be quick just because of the design of the sequence, is a single shot acquisition. This is an example from, again, one of our regional reference sites. It's a university hospital in Turkey, Kocaeli University. They have one of our latest machines there. And these are some examples of single shot acquisitions. And you can see the scan time, you can see the details, and mainly the SNR that you're not losing just because you're doing a very, very fast acquisition. In fact, this site has a combination of the latest technologies by GE. They have the deep learning reconstruction in combination with a new technology in coils that GE introduced, which is the air coil. It's a new way of designing coils. You're getting double benefit from the air coil itself as well as the deep learning network and deep learning reconstruction. This is another example from the same site in Turkey, again to show the impact on single shot acquisitions, diffusion acquisitions, as well as the ADC maps. You're able to see very, very small lesions on the liver with very, very high clarity as well. This is another example of single shot acquisition from, again, KFMC, King Fahd Medical City in Saudi Arabia. Same patient, 2018, they came back for a follow-up in 2021. You can see that the time, compared to the previous time, you did the scan in 1 minute 17 seconds versus almost 3 minutes. And I think you can appreciate the details in the image, the high resolution that we're able to acquire, as well as better SNR in the image. In this particular example, we improved spatial resolution by 45%, and the scan time dropped by 55%. So huge impact on the clinical practice, which I will show you later at a department level at one of these sites. Again, another example from the same site in Saudi Arabia. We've implemented, this is the full exam showing a comparison between 2018 and 2021. Again, same patient, just to show in every single sequence we're able to do better scan time, better image resolution, better SNR. We're no longer compromising between the 3 parameters. So what else can we do? We know that there are some exams that are challenging because of the anatomy, especially small anatomy. We have to have very, very high spatial resolution. Prostate is one example. A typical prostate exam today, if we follow the ACR, American College of Radiology, PIRADS protocol, will take, I would say, on average of 35 minutes if we want to follow the PIRADS protocol in terms of resolution specifications. What that means is a typical exam, a typical sequence will take around 4 to 5 minutes in this particular example. But by using deep learning reconstruction, by using this new way to remove noise, we're actually able to acquire the same sequence in only 90 seconds. What this translates to in terms of clinical practice, and this is an example again from our site in Turkey, is now a full prostate exam. ACR PIRADS protocols will not exceed 15 minutes of scan time. So we can go from scanning 1 prostate exam per hour to potentially, I would say very conservatively, 2 to 3 per hour. This is a huge impact on productivity for both public as well as private institutes. This is an example. We are very proud to have one of the first sites, one of the first global sites to implement this. The way we work is we approach several sites around the region and around the globe to implement this technology. This was done here in Egypt at the Advanced Diagnostics Center in Al Mansoura. They were the first to implement this technology in Egypt, and these are some examples from their site. This is a spine exam, a lumbar spine exam, where we're able to get this kind of quality in under 5 minutes consistently. Some other examples from the same site in Al Mansoura, again, C-spine exam, a full exam with under 5 minutes. These three images together, they are done using the conventional way to do reconstruction. And if you take the same raw data and you apply, you pass it through the deep learning network, these are the images that you will get. So you can see how we're using the same raw data. It's just a matter of how you do the reconstruction and how you're able to remove the noise from the image to get this kind of quality. Another MSK example, a full shoulder exam with this, I would say, fantastic quality under 5 minutes. Again, some other examples, I would urge you to look at the diffusion image. Beautiful diffusion images, single shot acquisition as well. Very, very high SNR, very high resolution. And then if we put all of this together, if we say, okay, what is the impact on my practice if I apply this technology versus not having it? So we've done this at some of the sites that upgraded their device to incorporate this. This is one of our sites in the UAE. It's in Sharjah, UAE, Qasimi Hospital. If you look at the table, you'll see the scan time they used to do per exam, per practice. So for example, brain was around 15 minutes. And if you go down the list, and you can see their prostate scan time was around 25 minutes. After we implemented what we call Recon DL, or air technology, deep learning reconstruction, you can see that in every single exam type, we were able to reduce exam time while simultaneously increasing spatial resolution. Another example from our KFMC site in Riyadh, again, consistently throughout every exam type. So the UAE example was a 3T. This example from Saudi Arabia is a 1.5T. The Mansoura Radiology Center is also a 1.5T. This technology can be applied to any type of field strength and is actually applicable on every GE MR device today. And this is the type of impact that we're seeing from the sites. And then one last, I will end with this one last slide. On this particular site, this was a public site, very, very busy site, huge demand on their workflow. They were actually able to save 1,500 minutes per month. You can see how many minutes they were able to save per exam type. And if you translate this to their daily practice, that's almost 4 patients per day extra without changing their shift schedules. So same MR, same technologist. By introducing this technology, this particular site was able to serve 4 additional patients, huge impact on their backlog, and obviously much better patient experience as well, because the patients are spending less time on the machine. It's easier for the technologist to scan. The availability of SNR now in the images is enabling technologists to have more consistent imaging as well. So with this is the end of the discussion. I'm more than happy to answer any questions you may have. Shukran.
بسم الله الرحمن الرحيم. الحمد لله, by the end of this talk of the people of GE, we finished our session. كل session وانتم طيبين وكل مؤتمر وانتم طيبين.